Hello friends. Today we are going to understanding about the topic is endotracheal intubation. So let's get on to the video. Myself Vinoli, working as a tutor in Tibulam College of Nursing. Let's see the objectives of the topics. What is endotracheal intubation? What are the types and indications of intubation and equipments required for intubation and techniques of intubation and confirmations of after intubation and ventilation and what are the complications of intubation and nursing managements of the intubation. So let's start with introduction to the topic. Endotracheal intubation is the placement of a special tube into a trachea. So there are two types of endotracheal intubation. One is oral intubation, which is the most commonest type, or other way is the nasal intubation. What is oral endotracheal intubation? Endotracheal intubation involves passing an endotracheal tube through mouth into the trachea. Intubation provides a patient's airway when the patient is having respiratory distress that cannot be treated with simpler methods. And also, it is a method of choice in emergency care. Let's see the indications of endotracheal intubation. So, the first one is to supply the oxygen, upper airway obstructions, for example, secondary to burn and tumor or bleeding, and high risk of aspiration, infective clearance and more secretions, and respiratory arrest or distress, and cardiac arrest, and for the general anesthesia, decreased level of unconsciousness who had a less than 8 level of the GCS. Risk for oral endotracheal intubation, obstructions of the airway by patient biting, and chipping and dislodgement of teeth, difficult for suspected spinal cord injury, mouth guard is a challenge, and increased salivation and difficulty in swallowing. Advantages of oral intubation. Larger tube can be inserted through the mouth. Tube can be inserted usually with the most pain and easy with less trauma, and easier suctioning through the mouth and less airflow resistance, and reduced risk of tube kinking when you're doing a oral endotracheal intubation. Next, let's see the nasal endotracheal intubation. The endotracheal tube is placed blindly through the nose and nasopharynx and vocal cord into the trachea. So, in case nasal endotracheal intubation, risks can expect kinking, uncomfortable for the patient, work of breathing is a greater, and suctioning is a challenge, and most expected for the infection, and ventilator associated pneumonia when you're doing a endotracheal intubation through a nasal route. What are the advantages of nasal intubation? More comfort long term, decreased gagging, less salivation, and easier to swallow, improve the mouth care, better tube fixation, and improved communications for the nasal intubation. Next, we'll move on to the equipment required for endotracheal intubation. The first one is PPE, personal protective equipment. For example, glove, mask, apron, and goggles. An intubation pillow, laryngoscope with blade, ET tube with lubricant jelly, stethoscope and stillet for metal wire, and Mangel's forceps for different sizes, and suction apparatus with tubing, connected to oxygen at 15 liters per minute, an ambibag with mask, and syringe 10 ml for to inflating the cuff, an oropharyngeal airway which is to preventing the tube biting, and adhesive to tie. Parts of the endotracheal tube. This is the 15 mm of connector and which is connected to the oxygen source, and this is the internal diameter and depth of the marker, and this is the level of vocal cords and Morphe's eyes, and this is the pivot to the tip of the point, and this is the cuff, and this is the pilot balloon which is the way of the inflating the cuff. These are the size of endotracheal tube and which is classified based on the age group. 0 to 1 years for 2.5 to 3.5 mm, and 1 to 3 years for 4 to 5 mm, 4 to 6 years for 5 to 6 mm, 6 to 10 years for 6 to 7 mm, adult female for 7 to 8 mm, adult male for 8 to 9 mm, which can be inserted. Functions of endotracheal tube, which is to provide a passage for gases to flow between a patient's lungs and anesthesia breathing system, and allows one to provide positive pressure ventilation and protect the lungs from contaminations from gastric contents and nasopharyngeal matter such as blood. Contraindications for endotracheal intubation. Severe airway trauma or obstructions, which is that does not permit safe passages of an endotracheal tube, and emergency cryotherapy is indicated such cases. And next one is cervical spine injury, in which is the need for complete immobilization of the cervical spine makes endotracheal intubations which is difficult. And Malapathy classifications of class 3 and 4th are the determination of potential difficult to airway. Next, let's see preparation. This is the commonest preparation for any procedure for these 4 domains. So, first thing is environmental preparation, and the privacy is any kind of patient which is most important, and floor, good lighting, and aseptic techniques, and patient for comfort the patient, and consent from the patients and guardian, and make sure the position and equipments already as I told, and personal thing is wash the hands and PPE, personal protective equipments. Technique. First, position the patient like maintaining the sniffing position, and raise the head by 5 cm with a block or ring pillow. And here, the position the patient with the supine position with the head extended by keeping sandbag or towel roll under the neck. And hold the laryngoscope with the left hand irrespective of the dominant hand, and open the mouth with the right hand index finger with the supported thumb, and introduce the laryngoscope from right angle of the mouth, and shift the tongue to the left and press over the tongue, and see the epiglottis lifted, and watch over the vocal cords. Next, we should take the endotracheal tube in the right hand, and before inserting the endotracheal tube, we should check the EG tube cuff like inflate and deflating, and place the stillet into the applied jelly, and smoothly introduce the under vision of the endotracheal tube into the trachea, and after that to remove the stillet and connect the amber bag and brain circuits, and suction the oral cavity if necessary. Confirm placement by auscultation and entitled carbon dioxide. If the tube is cuffed, inflate the cuff with a syringe. Connect the sources to the tube. For the confirmations by auscultation, by chest expansion, by movement, and entitled carbon dioxide. And inflate the cuff with 10 ml of air into the pilot balloon, and connect to the mechanical ventilator, and finally applies the adhesive tie to stabilizing the tubing. Post-procedure care. First, we should check the cuff pressure. Should maintain 20 to 25 mm of Hg, and pipe plug or oropharyngeal airway, which is to prevent the tube biting, and place the patient in lateral position, and arrange for chest X-ray in order to check placement of ET tube, and apply the endotracheal suctioning whenever is needed, and watch the chest movement in ET tube kinking or obstruction and leakage of the tubing cuff and over the inflation of the cuff. Complications of the endotracheal intubation. Tube in esophagus, endobronchial intubation, trauma to lips or tooth, bleeding and leakage for cough, and tracheitis, cough, sore throat, barotrauma to lungs. What are the nursing management for after ET intubation? So first, maintain the correct tube placement and patency, and maintaining the proper cough inflation and monitoring oxygenation and ventilation, and providing oral care and maintaining the skin integrity, and fostering comfort and communication, and prevention of the complication. Thanks for watching. Subscribe our channel.